Did you know over 1 in 1,000 people worldwide suffer from the primary immunodeficiency disorders, widely known as PID? But many remain unaware because the symptoms are often mistaken with the common illnesses. In India, many people, including the adults and children, live with PID without even knowing it. The signs are often common, like the recurring infections, constant cold, or unexpected fatigue. But the good news is with the early diagnosis and the right treatment can have the people who are suffering from PID live with healthy lives. Namaskar. Hello, my name is Krishna Verma, and I'm your host for this interesting podcast. We are diving into a very interesting topic, which is commonly unattended, which is the primary immunodeficiency disorders. This primary immunodeficiency week, which has been celebrated from the 22nd April to 29th April, let's focus on to creating awareness among the early detection and the diagnosis and the right management of PID. And for the same, we have someone very special to talk on PID. We have with us Dr. Dinesh Kaul, Senior Consultant Pediatrics, Infectious Diseases and Clinical Immunology, associated with Department of Pediatrics, Institute of Child Health, Sir Gangaram Hospital, New Delhi. We welcome you, sir. Thank you so much for taking your time out.
Thanks a lot. My special thanks to the host for inviting me over here. Uh, I think with these few questions, we'll be able to highlight some of the aspects which the pediatric population as well as the adult population of immunodeficiency patients need to know.
So, first and foremost question, what is PID, immunodeficiency disorders, and who can be affected with PID?
Well, the basic idea about whenever we say the immunodeficiency, it means we have an innate as an acquired immune system in our body which helps us to fight infections and other inflammatory responses. So people who have an inherent defect, so a lot of people have right from the birth, they are born with this genetic defect. So primarily they are genetic defects. They are born with it and they manifest it either in first year of life or they can manifest even in a later in adult life. So there is a spectrum of immunodeficiency disorders. Okay. So they
And
are basically genetic disorders.
wonderful to know that. And how common is PID in India?
Well, whatever data we have from the Indian population is basically a institution-based data. So there are tertiary care institutes all over India which are dealing with patients with primary immunodeficiency. So this may not reflect the total countrywide data in the common man, okay? Because this is the high risk people who land up here, who have symptoms. So we say that at least 1 in 2,000 would be an average incidence prevalence rather of an immunodeficiency in the common population. Out of that, there are certain subtle immunodeficiencies like hypogammaglobulinemia, IgA deficiency, which is quite commoner. But then there are other deficiencies like the severe combined immunodeficiencies, which are not so common. They may be in the 1 in 500,000 children may have a severe combined immunodeficiency. But if they have to be tackled earlier in life, first year of life, so that we can give a meaningful treatment to such infants.
So, what happens in the body when someone has PID, and how does PID affect the immune system?
See, basically, this is something. Immune system is that our body has a capacity to fight the invading pathogens. So we are in an environment of microbes. Our whole body is also laden with microbes, but they are sitting there. But then we are also in an environment where there are different bacterial infections, viral infections. Then, in addition to that, people may get different pathologies like cancers, like tumors, like they may get burns, they may be succumb to radiation. So, as a response to all these triggers, so our body tries to fight
Yeah,
these pathogens, these external environmental factors, and that's how the immune system comes into play. So, the immune system is basically the innate immune system and the acquired immune system. So, most of the mammalian organisms, even a fish, even a frog, a small microbe has its own immune system to fight the external challenges. Okay,
yes,
so that's called an innate immune system. We are born with
true.
that immune system. Then, over the as we grow, we in our body there are certain T and B cells, which are certain immune producing cells. So they are very important to mount a response to certain pathogens. There could be certain bacterial infections, viral infections, parasitic infections. And in addition to that, it is not our body can somebody can develop a cancer. So our body produces certain substances which are called immunoglobulins, which are called cytokines, to fight
True.
these
Yeah.
invading tumor cells, cancerous cells, or there's an exposure of an radiation. So our immune system comes into play. So that's called the acquired immune system. So the population can have both defects in the innate immune system as well as the acquired immune system. We know that most of our understanding for last 30 years has been with the acquired immune system. So we have classified them into the antibody deficiency defects, the T cell defects, the combined T and B cell defects. But there are a huge number of genetic defects. So there are at least, we know that there are at least more than 400 mutations,
Oh,
genetic defects which have been isolated till now, because there's a defect in the at the cellular level, at our genetic level. So then they lead to, once there is a defect at the cellular level, it leads to a phenotypic expression. So they get it manifests in different disease processes. So, say a child with an immunodeficiency might have recurrent diarrheas, may have recurrent respiratory infections, may need hospitalization quite frequent enough, may have a pneumonia. So that's why our mind triggers us to think whether these children who have recurrent infections, do they have an underlying immunodeficiency?
and as you said, what are the different kinds of PID?
Okay, to classify the different kinds of PID, so we have the T cell defects, the B cell defects, and we have a combined T and B cell defects. Then, in addition to this, we have certain, our body produces certain substances called complements. So, there could be a complement deficiency also. So, broadly, whenever we are classifying the acquired immune system defects, so we classify them into the T cell defects. They are more severe defects.
Okay.
They get recurrent viral infections. They're, say, a child getting an immunodeficiency, getting a bad chickenpox infection, which is a life-threatening chickenpox infection. Having a chickenpox encephalitis may have an underlying immunodeficiency. Or So most of us get herpes infection, either herpes labialis, lip, cold sores. But these children get a life-threatening herpes infections. They may get an infection of the brain called herpes encephalitis. So that's how this comes into picture. So they have a defect in the T cells.
Okay.
Another group of children or adults as such have a defect in the immunoglobulins. So these are certain proteins which are being produced by our body by the B cells, the plasma cells of the body, and they produce immunoglobulins. So there are various classes of immunoglobulins. So these children who have immunoglobulin deficiency, IgG deficiency, they can be a complete absence. That's called a gamma globulinemia, or if they have a little less innocuous deficiency, that's called a hypogammaglobulinemia. So that's a classic example of aglobulinemia. We know of Bruton's disease.
Yeah.
Okay, so it's one of the famous scientists. He was an army doctor for the lay public. So he was the person in 1952. He could just sense that a child, 7-year child, was getting recurrent pneumonias, recurrent ear infections. So he questions himself, why is he having these things? So that led to, he had a defect in producing certain proteins, certain immunoglobulins, IgG, way back in 1952. So this child got subsequently a replacement therapy for this immunoglobulin. So that's what, though we are using a very purified intravenous forms of immunoglobulins these days, but in 1950s they were using intramuscular. So that's how the research develops. So finally, basically, they are T cell defects, they are B cell defects, they are complement defects, and if you have a defect in the NK cells, so that's a defect of the immune system. So then that's we classify of the innate immune defects. They have a defect in the NK cells, the natural killer cells.
So there are a variety of them.
There are a variety of. Every year we get at least 1 or 2 immune deficiencies are being added to this list.
So the T cell is the most
Yes.
life-threatening, as you
Yes,
said.
T cell defects are more life-threatening defects. B cell defects are not that life-threatening defects. So whenever they have the T cell defects, they present very early. They will present first year of life, preferably within first 3 months of life, which have to be tackled at that point of time, because otherwise it is lethal. The children will die if we don't diagnose them upfront at 3 months of time, and we'll be coming to the therapeutic modality later on.
Yeah. So, as you said, all the immune system is all genetically based. So, what are the genetic causes of PID, and can PID be inherited too?
Yes, PID is primarily inherited. That's their parents, or the mother or the father is carrying the defective gene. So if the mother is carrying the defective gene, so that means they are X-linked diseases.
Okay.
So that means the mother is the carrier and the males have the disease in this scenario.
That's
so
why.
that's called an X-linked disease. So most of the cases in these, the males are affected, while as the females are the carriers. So this is nothing stigmatization, but this is the natural biology of this disease. But same way, females can be also affected with different autosomal disease. So most of them are genetic diseases. That means their parents have the defect. But then there are certain spontaneous mutations. That means when the baby is developing in the mother's womb, in the uterus, so it goes through a process of embryogenesis and different organ formation. The heart forms, the brain gets developed, and same way the immune system also gets developed as a part of the development of the blood and other hematopoietic system, the immune system. These cells also developed. So if they have a defect occurring at that point, so the children can manifest de novo. That means it's a spontaneous mutation. Their parents did not have this mutation earlier.
Okay.
But most of them are genetically driven. So the defect is that we don't know still the genetic phenotypes, genetic mutations of certain immunodeficiencies till now, but the understanding is changing over the years. We're looking at, because the newer genetic methods like the whole exome sequencing, what the scientists do in their labs, with that they can interpret and find out newer mutations.
Quite a research, and as Sir said that, every year there are new, types of
Being identified,
PID has been identified, and that's a wide thing. And are there any environmental factors that contribute to PID?
Well, as such, there is definitely a trigger of, mainly they have environmental factors are responsible for the autoimmune mediated diseases.
Okay.
So their autoimmunity is one process. It is wherein the immune system is also involved. That means, say, our cells are being targeted, what they are being supposed to do. Say a patient with a Crohn's disease or patient with an rheumatoid arthritis, they are autoimmune diseases. There is no infection involved in such diseases. So our body attacks certain cells of these, of
Yeah.
the immune system, attack the normal tissue. So they may attack the joint, the synovial, cause destruction of the synovial, leading to rheumatoid arthritis. Or they may get something like an SLE, systemic lupus erythematosus. Females are more predisposed to get SLE, so they get anemia, they may get various recurrent infections, they may get a skin rash. So there also the immune system is also involved. So they are called auto-inflammatory disorders. So it's basically, that's where the environment comes into play. But most of the time these are genetically driven. So you are born with these defects.
And what are the common symptoms of PID, way among different types too?
Well, it depends upon the what is the genetic defect of these PIDs.
Okay.
Say if the child is born with a B cell defect, that means the child has hypogammaglobulinemia or agammaglobulinemia, or adults having an what we call as a common variable immunodeficiency. So they have a defect into the B cells.
Okay.
That means their B cells at different size, different type of maturation. So or cells are being produced from the bone marrow. So from bone marrow they are as basically plasma cells, the B cells. Then they mature into the bloodstream. They form the proper B cells. First the pro B cells and then the B cells, and then these B cells produce certain proteins called immunoglobulins.
Okay.
And there could be a defect into the production of these immunoglobulins. So they are called hypogammaglobulinemia. These children manifest later, around 6 months of age, when the maternal antibody response dwindles down. Because once the baby is in the mother's womb, there is a transplacental transfer of antibodies to the baby. So subsequently, the baby also starts to produce its own antibodies. But in these conditions, in hypogammaglobulinemia, the babies don't produce enough of IgG. So they manifest after 6 months of age.
Okay.
When the maternal immunity has decreased, maternal IgG is being cleared off and the baby is not producing enough antibodies. So they are liable to get recurrent diarrheas, they may get recurrent pneumonias, they may have failure to thrive, they don't grow well, they don't put on weight, they may not feed well, they may be listless,
Hmm.
they may have anemia if they have a defect in the red cells also concomitantly. So, but in contrast to this, the T cell defects
Hmm.
will present earlier. So these T cell defects present within first 3 months of life.
Yeah.
So they within first 3 months, the child will be having a very severe life-threatening infection of a pneumonia. They may get as a very atypical pneumonia called PCP pneumonia, pneumocystis carinii pneumonia,
Hmm.
or they may get a severe herpes infection, or they may get a CMV infection.
Hmm.
Okay, these present quite early. That's
Hmm.
called the T cell defect. So they can be, that's all we call as a, then there are a combination of T and B cell defects. So we call them SCIDs, severe combined immunodeficiency. The defect is in both at the T cells and the B cells.
Okay.
Then there is adults have a little lesser antibody defects. They are called common variable immunodeficiency. They present later. So they may present later as late as 30 years of life.
Oh, is it?
So this adult may present to a gastroenterologist or with a rheumatologist with a joint swelling,
Yeah.
with a diarrhea, recurrent diarrhea, which is not settling down with antibiotics, which is not infective
And
diarrhea.
that has been connected with
Yes,
PID.
then we say that they have an underlying either an IgA deficiency or they
Oh.
have a common variable immunodeficiency. So these adults also subsequently will need a supplemental IVIG, immunoglobulin therapy. So if
Oh.
we give these adults monthly IVIG, though it is definitely costly affair,
Mhm.
so but they do well, they don't have diarrheas, they don't have recurrent infections, and they can lead their life normally.
Oh, that's quite some. And now, if we talk about the early warning signs of PID, or how can the PID be diagnosed?
Whenever we have certain early warning signs which has been sort of given by a foundation called Jeffrey Model Foundation.
Okay.
So this foundation came way back in America about 40 years back
Mm-hmm.
when their children had underlying immunodeficiency. So there were a lot of philanthropic activity going around those. They started this foundation. So they have, in consultation with the doctors, with the scientists, laid certain guidelines.
Mm.
So these guidelines are primarily meant for the lay public who may not have a very good understanding of the biology. So we tell them if a child is having recurrent ear infections, say more than 4 or 5 ear infections in a year, or if they are getting more than 2 pneumonias in a year, or they are getting different discharge of a pus which is not healing, or an atypical bacterial infection in which organism is not supposed to be there.
Okay.
Okay, the child has failure to thrive, the child is not growing well, is not putting off weight. Okay, there are at least 10 warning signs given by this foundation. But as from the doctor's perspective point of view, from the pediatrician's point of view, we evaluate most of the children. Whenever it strikes us this child is sick, he doesn't have an underlying commoner cause for his disease, and say if a child is getting a liver abscess in a good environment, we're bothered, why did he get the liver abscess, why did he get a liver infection? So we like to evaluate this child for underlying immunodeficiency.
So even if I can ask, if a child is getting recurring eye infections, is it also connected with PID?
Yeah, not recurrent. If they children who are getting recurrent boils, so if they are getting recurrent furuncles, a big furuncles,
Okay.
pus points over the skin.
Okay.
Uh,
It could be for the eyes also.
It could be if they could have a recurrent bacterial conjunctivitis, but most of them have certain skin infections, so
Okay.
they may have an underlying which we call as a chronic granulomatous disease,
Okay.
or they may have one more immunodeficiency called an IgE deficiency, which they may manifest later as adolescents or adults also. This is called the Job syndrome. So they have recurrent boils, their facial features are a little different. So we can, as doctors, were trained to pick up these signs for the population so that we look for their underlying immunodeficiency. So basically, recurrent diarrheas, recurrent ear infections, in an unusual infection which is not supposed to be there, or unusual organism which we don't see. We see in say cancer patients, and we're finding in some other population. We would, need to evaluate such adults and children for immunodeficiency.
So, what tests are commonly used to diagnose PID?
Well, we have, this is a little costly affair, and we need to have a good lab. But fortunately, over last 30 years, things have changed.
Okay.
So every biochemistry lab, every hematology lab in any government hospital or a private setup will have the facilities for detecting immunoglobulin levels. So that's the basic test which needs to be done. Okay. Then, so once we can do a IgG, IgA, IgM, that's called an immunoglobulin profile. So most of the labs can do this basic test. We can do the CBCs, the blood counts, the blood chemistries need to be, they do get altered in these patients, and they are sort of markers for us that these children may have immunodeficiency. Okay, say a infant who is having recurrent boils, and we do a simple total leukocyte count, a blood count, and we find this child has a count of 30,000 or 60,000 in first year of life. So we may think that they have a defect called a leukocyte adhesion defect. So that's sort of and there are certain cells of white cells, they are called neutrophils. They have a defect in their neutrophils. So that's called a chronic granulomatous disease. So the treatment for these is antibiotics, immunoglobulins, but the curative treatment is a bone marrow transplant.
Oh.
So most of the labs can do immunoglobulin profile. We need a good sophisticated hematology lab or a genetics lab to do what we call as a flow cytometry. So that flow cytometry is done in a lab which has a flow cytometer, and that analyzes certain cells, the T and the B cells. We need to have their enumeration, and then we can say whether they have their T cell counts or B cell counts are low. They are basically a type of lymphocytes. So in fact, white blood cells, a subset of white blood cells. So we need to have, then one more way ahead is the genetic test. So very few centers in India have the genetic facilities, but yes, we are trying to develop them in different centers. So because the diagnosis will be the genetic diagnosis. So if we have to offer something for the mother who has a child with an immunodeficiency, so we have to have a genetic test for this baby so that we can test the mother in the antenatal period when she is pregnant, so that this baby doesn't have that particular defect. Otherwise, the subsequent pregnancy she may be harboring that.
So how can this be done? She'll be given some medications?
No, she will not be. This is a process called, either we'll do a blood test from the mother, we'll do a check whether she is having the particular mutation. Okay. Or in certain cases, we do, the baby is enveloped in the amnion and the chorion. the membranes which cover the baby in the uterus. So we take a biopsy through the ultrasound
Okay.
from the mother, and we subject take this tissue, though it is an invasive test, but that is subsequently analyzed in the genetics lab for the mutation. So we have to have the child's mutation. We can subsequently test the unborn baby's mutation.
Okay.
So if this unborn baby has also the mutation, then we know that, well, then we give them, there are various options. The mother
Okay.
has to decide, depending upon the severity of the disease, we need to take further action.
Oh. So, and how long does it typically take to diagnose the PID?
See, as far as the hypogammaglobulinemia is concerned, we can diagnose it by 6 months of age,
Okay.
by 1 year of age. So if they present as early as 6 months of age to us, for T cell defects, we have to be very vigilant. We have to diagnose them very early, around at 3 months of time. Otherwise, the scope of therapeutic intervention for us is missed, because for severe combined immunodeficiency with SCIDs, the modality of treatment is a bone marrow transplant.
Oh.
So that is a costly affair, but over the years, a lot of foundations are coming with to help these children with the funding for the bone marrow. You have to have a matched or a 50% matched donor.
True.
So the brother or the sister can be a donor for such children, or sometimes we look for from the general population. So there is a very sophisticated test called an HLA matching. So we have to do an HLA matching for a bone marrow transplant. But for simple SCIDs, a 50% match from a mother or a father is enough for us. So we can take the bone marrow from the mother and the father, or the peripheral blood from the mother and the father. Then this baby is given, the affected patient is given that blood. And prior to that, obviously, there are various methods which we have to ablate his own bone marrow, the defective bone marrow, and then the new bone marrow has to be infused in the patient. So it's definitely a complicated procedure. There are hematologists who are doing these procedures. We have at least 10 to 15 centers in India doing regular bone marrow transplants, both for immunodeficiency patients and or for other reasons. They may have thalassemia or leukemia or something else.
So, what are the general treatments of PID?
Well, the mainstay of treatment, the general treatment to support them till we find their cause, is the replacement IVIG.
Okay.
Because most of them, 50% of the patient population in India have hypogammaglobulinemia. That means their IgGs are deficient. So they have to be given replacement monthly or 3 weekly IVIG, immunoglobulin therapy. So we give them around 400 milligrams per kg dose. So that's if it's a 30-kilo child, so that's a little costly affair.
True.
So these days, over the last few years, the immunoglobulin therapy has become quite costly. But there are certain states in India where the government is funding the IVIG therapy for such children. So in fact, I would really request the concerned authorities that they should look into this matter. We should have an indigenous IVIG production in India, so that it is cheaper, it is acceptable, it is from our population, and mainly, and it is freely available, because these are the patients who need IVIG. So most of the IVIG is being, in fact, imported at this point of time. There are certain, obviously, regulatory issues involved with it, but my sincere request for the authorities would be that they should seriously look into the provision of IVIG therapy for such children.
I guess, this would be addressed to our Honorable Prime Minister Narendra Modi ji, wherein, the IVIG, where we're importing, it becomes very costly, or a fact in India. Why not the Make in India can take up this ahead and, be available to the needy ones in India too? Coming back to the next question, sir. Um, how does immunoglobulin how does immunoglobulin therapy help in managing PID?
Well, as I said earlier, the basic defect is they lack the production of the immunoglobulin. So these are proteins, IgG especially, which is defective. They may be producing it, but that's not functional, or they produce it at a lesser quantity. So ideally, we would have an IgG level of around 800 or 1000 milligrams per deciliter in the blood. But these children have very low levels. They may have as low as 100 milligrams per deciliter. So
Okay.
because of the lack of this immunoglobulins, they are very important for certain condition, for fighting the infections, for I can't use a lot of technical words at this point for called an opsonization
Okay.
of the bacterial pathogens. So they are the first, more or less, the second line of defense, which are important to take care of the infections. So whenever our organisms get into our body, so our cells take care of it, or neutrophils take care of it, or lymphocytes take care of it, and the immunoglobulins are very important to take care of this, controlling this infection. So they need this monthly IVIG. So this has to be given intravenously. So
Okay.
it has to be, they have to be hospitalized, or they have to go to a daycare center, or even if they're home, if they have the facility of giving an intravenous immunoglobulin. So a paramedic, a nurse needs to give them an IV infusion. It has to be given over 4 to 6 hours. But fortunately, now Indian companies are coming up with the subcutaneous intravenous immunoglobulin. That means this adult or a teenager who is going to the college can use a small portable infusion pump, whereas syringe is fitted and with that can go in the skin. So overnight, once he is sleeping,
Oh.
over 8 hours, he can take the subcutaneous infusion of this medicine. So
Okay.
this can't be taken orally. It's not a tablet formulation,
Oh.
because it gets destroyed in the gastric mucosa, so it will not get absorbed from the stomach. But let's hope we have research in the offing that we will have some things, a sub-implantable patch or something like that, where it will be slowly releasing the immunoglobulin into the body. Second modality would be, which I missed, is the bone marrow transplant. So a therapeutic modality is the BMT for severe immunodeficiency patients, severe combined immunodeficiency patients. So they need this. That is the, or children with chronic granulomatous disease or leukocyte adhesion defect. That is the curative modality for these conditions. Then there is a defect called the complement defect. So there are certain other subtle proteins. So they do get a defect in their complements, or there are a lot of certain pathways in the complement also, but we call it C1 esterase enzyme deficiency. So we have now C1 esterase enzyme is readily available, but though it is costly, so that can be used as a replacement for these patients. But we need to know where is the defect, what is the defect, at what level does the defect. Then only we can help them out with the modality of treatment and management.
The proper diagnosis.
Proper
is
diagnosis.
is
Once we
necessary.
have the proper diagnosis, then only we can help them out with the therapeutic intervention.
Yeah. So, with so much of research and the technology developing, what are the new treatments for PID?
Well, one of the important would be a genetic treatment. That means you have, if I would, the defective gene could be taken out from the cell
Oh,
and put a new gene is put in that cell which
right
is
from the
defective.
beginning.
That is the in thing. So there
Oh,
are genetic therapies for skid, at least for, there's a condition called adenosine deaminase deficiency, ADA deficiency, where
okay.
we have the genetic therapy. So though we are really in infancy, we have not been able to start really genetic therapy in India as of now, but there are centers in Europe, in US, which are using genetic therapy as a part of treatment of immunodeficiency disorders. Then there is a defect also called the, we have a gland here, the thymus.
Hmm.
So certain children are born with absence of that thymus.
Okay.
That's called a D. George's syndrome. So there are centers in UK which are doing a thymic transplantation.
Oh,
So they can take thymus, normal thymus, from some other children where we need to remove the thymus. Say a child who undergoes a cardiac surgery, they take off their thymus as a part of the cardiac surgery. This thymus can be transplanted in
okay.
the affected children who have deficiency of
Thymus.
like D. George's
Okay.
syndrome. They have a thymic absence, so that may help them. But this is really in the infancy. About just 60 or transplants, thymic transplants, have been done in UK Great Ormond Street Hospital, London. So that is, we are keeping our hopes alive. But at this point of time, the immunoglobulin therapy, replacement IVIG, the bone marrow transplant is the modality of treatment for these immunodeficiency disorders. But then there are a lot of other autoimmune disorders. I have not touched the part of the autoimmunity. So we have, which the rheumatology colleagues deal with. So these children or adults present with autoinflammatory disorders. So how we used to treat rheumatoid arthritis or SLE these days, 20 years back, has completely changed. We have newer biologicals. So we have seen the COVID is one of the best examples of how we have treated COVID patients with certain biologicals. So their whole course of infection was obviated once we gave them the right biologicals, be it tocilizumab, be it certain other
Okay.
biologicals. So they change the infectious nature, the pathogenicity of COVID patients to some extent.
Okay. So, as I started off the podcast with saying that uh, mostly the PID has got very common symptoms as the common illnesses. So, how can you earlier, say that this is not the common illness, but it has got something to do with PID, and we can go ahead with the diagnosis?
Yes, see, over the years, we have also become a little more smarter. The diagnostic facilities have changed quite a lot. So we are picking up PIDs with the slightest doubt. So those children who present with uncommon infections at unusual places, very
Okay.
prolonged stay of infection in the hospitalization with the infection which doesn't go with antibiotics. You are giving the right antibiotic, but it still doesn't go. They are
So
not
the doctors
they
suggest.
are not drug resistant organisms, so
Ah,
we think that they may have an underlying immunodeficiency.
okay.
So we work these children up for underlying immunodeficiency, try to find out what type of immunodeficiency they have, And then they give them the option that this is if they have most of the 50%, as I said, may have have a hypogammaglobulinemia. So just merely giving them replacement IVIG will change the nature of their illness.
Okay.
Antibiotic therapy is very important for such children and adults who get recurrent infections. For autoinflammatory conditions, they need certain biologicals, though they are costly, but they change the nature of their disease.
Okay. So, what are the lifestyle changes that could be done to prevent or to avoid or to manage PID?
See, as such, one set of children, those who are uh, at the time skid, so these are very vulnerable to infections. So we would try to isolate them,
Okay.
protect them in a sort of home care environment where minimum visitors visit them till
Okay.
they get the replacement therapy, bone
Okay.
marrow transplant. Okay.
Ah.
But rest of them, we for hypogammaglobulinemics, we don't restrict their physical activities, but we tell them, yes, you need to get monthly IVIG, plus they need to get certain vaccines, prophylactic vaccines, so that they don't get recurrent pneumococcal or meningococcal or other infections. So whatever prophylactic vaccines are available, so we would try to administer these vaccines to these children with hypogammaglobulinemia. Say they are less susceptible to infections. Okay. And those who have IgA deficiency or who have an CVID, will tell them not to eat out, not to eat a lot of street food where they may pick up certain, say, a very parasitic infection leading to diarrheal illnesses. So that's the life. Otherwise, we don't restrict their activity as such.
Okay. And what are the common myths about PID?
Say the common myths are that, well, can an alternative medicine help it? That's the commonest myth. That's true for every disease where we don't have a final answer.
True.
So they may go to a person with an alternative medicine which may promise them that this gets cured, but which is not the scientific fact. We know in our heart of hearts it is not going to be okay. So the cost therapy drives them to going to different alternative medicine. So our idea is that we have to substantially decrease the cost of the medicines. A lot of medicines are definitely they are exempted from the duty, import duty, and all that. And that is the initiative as the government has already done for these children. But there's a lot to go in this scenario.
And so, what are the facts that dispel these myths?
Well, the public awareness is very important.
Yeah.
Be it the forums of the newspapers, in the doctor's clinic. We did, in fact, an awareness about the primary immunodeficiency this morning. As you said, this week we are celebrating as an immunodeficiency, rather 20th to
22nd to
29th
29th of
April is the
February.
immunodeficiency week. So we did a sort of an walk into the Central Park of Connaught Place in Delhi with patients and students, medical students, and an NGO foundation who deal with the immunodeficiency. So there are a lot of NGOs in India as well as abroad working to help these children, adults, and to just dispel the myths that this is not an untreatable condition. So if you seek the right advice at the right time, we can help them.
And what should someone do if they suspect that they or a loved one has PID?
Yes, most of the time, if their brother or sister has a PID, they will definitely get in touch with their healthcare professional. They will try to it's best for us to find out what is the exact disease. Are they having a hypogammaglobulinemia? Is there a complement deficiency? What is the underlying what is the underlying disease? Then
Any
only,
specialists that they have to
yes,
consult?
they have to see primarily an pediatrician or an adult infectious disease specialist, or an they may land up with a rheumatologist,
Mhm.
they may land with a pediatric or an adult immunologist, or they may land up with a cancer physician. So everybody of us is more of us trained over the years to look for immunodeficiency, and then we can it's basically a communication between different persons, so then only we can help them out.
So, how can the general public support PID research and awareness work?
Well, I'm not really sure whether general public can. Well, if we have certain trials, clinical trials going on, the normal volunteers can come out as a volunteer for getting a drug or an IV, newer IVIG which is being tested, or the patients can come over who need an IVIG. Say an X, Y, and Z company is launching different IVIG project which needs to be tested. So we do a lot of clinical trials for such drugs. So that's the mainly is the awareness. So I think it's very important for the people to look at the right information. So the right information may not always come from the WhatsApp messages which are circulating. So somehow they have to look, they should look for the information for particular government organizations, certain NGOs, certain official websites of the pediatric or the adult
Mhm.
associations, where they will get the right message. So that's my sort of an, I would request the public to do so.
So, what are the takeaways for our audience today about PID?
Well, a simple takeaway message for the audience is that it is treatable. Uh, we should be aware of an underlying that there is something called a primary immunodeficiency. We call it now basically now primary errors of immunodeficiency disorders. Uh, in rather inborn errors of immunity.
Mhm.
That's how there's a new name, but the old name still
The
stays,
primary
primary
immunodeficiencies.
immunodeficiency. So to tell them that these children could have an underlying hypogammaglobulinemia, uh, they can be treated with as simple as giving a monthly IVIG, but those who have subtle T cell deficiency or a combined T and B cell deficiency, which are presenting very early in life, first year of life, with life threatening infections, with hospitalizations, consult your healthcare provider. You may ask them, are you looking in from the immunodeficiency point of view? So they may consult somebody who has the facility and the experience of treating such children and adults. So that's what the public can do at this juncture.
So, awareness is very important, and I'm sure with the Primary Immunodeficiency Week that has been celebrated from 22nd of April to 29th of April, there are many NGOs and authorities working to get the awareness done in the common public. So you can share this podcast with your friends and loved ones and spread the awareness too. Thank you so much, Dr. Dinesh Kaul, for with a detailed information on the PIT. We are very thrilled and we are very honored to have you on the podcast.
Thank you, Ms. Krishna Verma. Thanks a lot for hosting me here. My special thanks to the people I do represent to some extent the IPSPI. This is the Immunodeficiency Society for Patients Organization Society, for which I'm trying to give them some technical help, be a part of this to create a public awareness for this disorder. Thanks.
Thank you so much and see you soon in the next podcast. Be healthy, be aware.